What if I told you that one of the earliest, most reliable warning signs of a massive heart attack doesn't actually happen anywhere near your chest?
Yeah, it's wild to think about, but it's true.
Right. And what if taking a prescription for, a little blue pill is basically the medical equivalent of putting black tape over a flashing check engine light on your dashboard?
Exactly. You're just ignoring a ticking time bomb right there inside your cardiovascular system.
Welcome to today's deep dive. We are completely reframing how we think about erectile dysfunction, or ED. We're moving way beyond that standard here's a prescription, have a nice weekend kind of approach.
Oh, absolutely. It completely reframes a condition that most people, and honestly, a lot of doctors too, treat as just a frustrating, maybe embarrassing, but ultimately isolated nuisance.
Yeah, and we are finding out that it is so much more than that. Our source material today is this really fascinating, highly detailed clinical article by Dr. Corina Ianculovici,
Right. She's the founder of the Morrell Institute for Longevity and Regenerative Medicine.
and a faculty trainer for the Cellular Medicine Association.
Mm.
Her work is really pushing the medical community to stop viewing ED as this simple plumbing issue.
Yes. She argues that erectile deterioration is actually a complex body-wide system failure.
Which brings us to our mission for today. We want to help you understand how viewing ED as that system failure provides a critical, literal window into a man's overall longevity and metabolic health. Okay, let's unpack this.
Yeah.
Because historically, a patient walks into a clinic with ED, and the doctor asks one very narrow question, right? Like, what chemical can we give this patient to produce an erection today?
Yeah, and that narrow question inevitably leads to a narrow solution.
Prescription pad.
Exactly. But Dr. Ianculovici pushes for a much deeper inquiry. She's asking, why has this specific patient's erectile physiology deteriorated in the first place?
Right.
And to really grasp why that question changes everything, I mean, we have to establish what an erection actually is. It's not just a simple mechanical hydraulic action.
It's way more complicated.
It's a highly demanding neurovascular event.
Neurovascular, so meaning a partnership between your nervous system and your blood vessels.
Right. But it goes even deeper than that. You have to think of it like a symphony.
Okay.
You need this perfectly coordinated interaction between your cardiovascular system, the vascular endothelium.
Which is the ultra-thin inner lining of your blood vessels, right?
Spot on. So you need that, plus nitric oxide signaling, your autonomic and peripheral nerves, cavernosal smooth muscle, hormonal signaling, your pelvic floor musculature, and your psychological state.
Wow. I mean, that is a massive biological checklist.
It really is. The whole process starts as a neural signal in the brain. That signal travels down the spine and tells the local nerves and that endothelial lining to release nitric oxide.
Okay, nitric oxide.
Right, which is the crucial messenger that tells the smooth muscles inside the penile blood vessels to just relax.
Got it.
Once they relax, arterial blood rushes in, the tissues expand, and then finally, the veins that normally drain the blood out, they have to be compressed to trap the blood and maintain rigidity.
So if even one of those instruments in the symphony plays out of tune, the whole performance fails.
Exactly.
And the source points out that for many men, they don't have just a single cause of ED. Like I might be dealing with a slight vascular issue combined with, say, mild insulin resistance, a dip in testosterone, and maybe even the side effects of a blood pressure medication.
Yeah, and they're all stacking on top of each other.
Which sounds overwhelming.
It can be. But that stacking effect points us directly to the most vital dependency of the entire process, which is endothelial health.
The blood vessel lining.
Right, because the cellular processes that cause coronary artery disease, things like chronic hypertension, diabetes, insulin resistance, dyslipidemia, smoking, obesity, those are the exact same root causes that destroy erectile function.
Hold on, I'm going to make sure we really understand the mechanism there. How does something like insulin resistance, which is basically your body struggling to process sugars, how does that physically stop an erection from happening?
Well, think of the endothelium like the non-stick Teflon coating on a frying pan.
Okay, I like that visual.
It's supposed to be perfectly smooth, allowing blood to flow easily and reacting instantly to chemical signals. But when you have chronic high blood sugar and insulin resistance, it creates systemic inflammation and oxidative stress.
Oh, I see.
Yeah, that stress literally scrapes away and damages that Teflon coating.
So the blood vessels become stiff and dysfunctional.
Incredibly stiff. A damaged endothelium just cannot produce enough nitric oxide.
And without nitric oxide.
The smooth muscle never gets the signal to relax, so the blood simply cannot flow in.
Wow. You know, if you're listening to this and thinking, look, I just want a quick fix so I can get on with my life, You aren't alone. I mean, that's how we've all been trained to think.
It is.
But using a standard ED pill when your endothelium is damaged is literally like cranking up the heat on the stove. But it doesn't do a single thing to repair that scraped Teflon pan.
If we connect this to the bigger picture, that is the crucial takeaway. The Prince and the Futh consensus, which is a major set of clinical guidelines in this field, they emphasize that any man presenting with erectile dysfunction needs to be immediately evaluated with cardiovascular risk in mind.
Because it's not just a bedroom inconvenience, it's an early warning system.
Precisely. For a huge portion of men, ED is the absolute earliest clinically visible manifestation of systemic endothelial dysfunction.
Why is it the earliest, though?
Because of the size of the plumbing. The arteries supplying the penis are roughly 1 to 2 millimeters in diameter.
Okay.
The coronary arteries supplying your heart are about 3 to 4 millimeters, so those penile arteries are much smaller. They clog up and show symptoms years before the larger heart arteries do.
That is terrifying. But also, I guess, an incredible opportunity to catch a heart attack years before it happens.
Exactly. And that's why Dr. Ianculovici outlines this modern regenerative approach. Step 1 isn't just writing a prescription, it's establishing a baseline.
Right. Measuring the dysfunction objectively.
Yeah, using validated questionnaires like the EIF-5 or the SHIM, the Sexual Health Inventory for Men, you have to quantify the baseline.
Because if you don't have a starting score, you have no idea if your interventions are actually improving the tissue over time or if you're just masking the decline.
Exactly. And then step 2 is the functional cardiovascular and metabolic evaluation, checking blood pressure, fasting glucose, waist circumference.
Basically asking about the health of the entire biological supply chain, not just the final destination.
Right. You cannot inject a regenerative therapy or prescribe a hormone and expect the local tissue to miraculously repair itself while the entire body is in a state of inflammatory crisis.
Which transitions us perfectly, because if it's not just a simple blood flow issue you can fix with a pill, I know exactly where people's minds go next.
Hormones.
Yep, hormones. The assumption out there in the wellness space is always low T equals ED. Fix the testosterone, you fix the erection. Is that actually true?
Well, it is the most common assumption, and arguably the most misunderstood aspect of men's sexual health.
Really?
Yeah. Now, to be objectively clear, testosterone is heavily involved. It regulates libido, sexual motivation, it supports that vital nitric oxide signaling we talked about, and it helps maintain the structural integrity of the tissues.
Sure.
If a man has clinical hypogonadism, like truly low testosterone, that absolutely must be evaluated and treated.
But the source explicitly highlights that simply optimizing testosterone does not automatically restore erectile function.
It absolutely does not. And the clearest proof of this comes from a landmark piece of research called the Traverse Sexual Function Study.
What did they find?
Well, they looked specifically at hypogonadal men, men with legitimately low testosterone, and administered testosterone replacement therapy. And their sexual desire improved dramatically.
Okay, so they felt better.
Right, their overall sexual activity increased because the psychological and hormonal drive was back online. But when researchers looked for a statistically significant improvement in actual erectile function compared to a placebo,
Let me guess. It wasn't there.
it simply wasn't there.
Wait, so even if a guy has the testosterone levels of a 20-year-old athlete and he feels incredibly motivated with a high libido, he could still completely fail to get an erection if his vascular system is compromised.
That is the harsh reality for many men. Think of testosterone as the software, the electrical signal, the motivation.
Okay.
But testosterone cannot magically clear out physical plaque from atherosclerosis. It can't reverse diabetic nerve damage or soften fibrotic scar tissue.
So it's basically sending a really strong signal to a broken piece of hardware.
That summarizes it perfectly. Hormones represent just one pillar. If the local vascular hardware is structurally damaged, upgrading the software isn't going to get the machine running.
Wow. Okay, so is sildenafil, your standard blue pill, is just temporarily forcing a pathway open without repairing the pan, and testosterone is just sending a signal to broken pipes. Are guys with vascular damage just out of luck? Like, how do doctors actually heal the physical tissue damage?
This is where the field shifts away from symptom management and moves into regenerative medicine.
Here's where it gets really interesting, because the source introduces something called the P-shot. And I know it's a platelet-based therapy, but how does injecting a patient's own blood into that specific tissue actually heal anything?
So it relies on platelet-rich plasma, or PRP. The protocol was originally standardized as the P-shot by Dr. Charles Runels,
Right.
and it involves drawing the patient's blood and spinning it in a centrifuge to isolate the platelets. Then they activate those platelets using calcium chloride.
What does that do?
It's a chemical reaction that converts a protein called fibrinogen into fibrin, which creates a platelet-rich fibrin matrix, or PRFM.
So it creates a sort of biological scaffolding.
Yes. And when those concentrated platelets are activated in that matrix, they release a cascade of powerful signaling molecules.
Like what?
Key proteins like vascular endothelial growth factor, or VEGF, and platelet-derived growth factor. The biological intent here is to trigger angiogenesis.
Angiogenesis, meaning the creation of entirely new, healthy blood vessels?
Exactly, creating new microvessels alongside tissue remodeling and neurovascular repair.
Let me contrast this with the traditional medication for a second. So a PDE5 inhibitor, like gadolinium, works by blocking an enzyme, which artificially forces the blood vessels to stay relaxed for a few hours.
Right.
But once the drug leaves your system, the vessel goes right back to being stiff. But PRP is actually attempting to give the tissue a biological software update so it can function on its own again.
That is the fundamental conceptual difference. Regenerative therapies aim for actual structural repair.
That sounds amazing.
It does, but we have to provide a crucial caveat to the listener here. Biologic plausibility in a laboratory does not automatically equal definitive clinical proof in human beings.
Meaning, just because the mechanism makes perfect sense on a whiteboard doesn't mean it works flawlessly for every single patient who walks into a clinic.
Exactly. We have to be highly objective about the clinical literature. And right now, the evidence is mixed.
Really? How so?
Well, Dr. Ianculovici cites a randomized, placebo-controlled trial by Poulios and colleagues. They studied men with mild to moderate vasculogenic ED. And at the 6-month mark, the men who received PRP showed a clinically meaningful improvement in their erectile function scores compared to the placebo group.
Well, that sounds like a massive breakthrough.
It is highly promising. However, we also have to look at a 2023 double-blind, placebo-controlled study by Masterson and colleagues.
And what did they find?
They found that while PRP injections were well tolerated and very safe, they did not demonstrate any significant efficacy advantage over the placebo in their specific studied population.
Wow. Why is there such a massive discrepancy between those studies? Is one of them just wrong?
It's not necessarily that one is wrong, it just highlights the sheer complexity of studying regenerative medicine. I mean, clinical trials vary wildly in their methodologies. They use completely different centrifuge systems, which results in different platelet concentrations. They use different activation protocols, different injection patterns, and honestly, most importantly, they select different types of patients with varying severities of disease.
So someone reading a positive headline about general PRP shouldn't just automatically assume that the branded clinic down the street is going to cure them with a proprietary shot.
Informed consent is vital here. Because of these mixed results, major urologic guidelines still consider penile PRP to be an investigational treatment rather than a standard first-line therapy. It has immense potential, but it is an adjunct therapy. It's just one piece of a much larger puzzle.
Okay, so we've talked about blood flow, we've covered the hormonal software, and we've explored cellular healing.
Yeah.
But isn't there a purely physical, mechanical side to this, like the literal muscles themselves?
Oh, absolutely. You're referring to the pelvic floor. And it is staggering how often this foundation is completely ignored.
Because the penis doesn't operate independently.
Right. It is anchored to the pelvis.
The article mentions specific muscles, the ischial cavernosus and the bulbous spongiosus. Try saying that 3 times fast. How important are those muscles, really?
They are mechanically critical. During an erection, once the blood flows into the tissue, those specific pelvic floor muscles physically clamp down.
Okay.
Their contraction drastically increases the pressure, which traps the blood and maintains the rigid phase.
So a guy could have perfect youthful testosterone levels, totally clear coronary arteries, and great blood flow. But if those specific core muscles are weak and fatigued, the blood just drains right back out.
Exactly. The mechanical lock is broken.
It sounds like physical therapy, like going to the gym. You can have an incredibly strong heart, great cardiovascular endurance, but if your core muscles are weak, your deadlift is going to fail every single time. We're literally talking about physical therapy for erections.
The clinical data completely backs up that analogy, too. The source highlights a randomized controlled trial focusing on pelvic floor exercises with biofeedback for men dealing with ED. After just 6 months of rehabilitating those muscles, 40% of the men regained completely normal erectile function
Just from physical therapy.
just from that. And another 35.5% saw a significant improvement.
That's over 75% seeing real-world improvement just from treating it like a muscular deficit. That is wild. Which brings us to a specific technology mentioned in the article, Emcella. What is that?
So Emcella is a device that utilizes high-intensity focused electromagnetic stimulation, or AFEM.
Okay, how does that actually work in an office?
Practically speaking, a patient sits fully closed on a specialized chair, and the electromagnetic field induces thousands of supramaximal pelvic floor muscle contractions in a single 28-minute session.
Hold on, let me play devil's advocate here for a second. If Emcella is basically just an incredibly intense Kegel machine, why can't a guy just look up Kegel exercises on YouTube and do them at home for free? Why pay for electromagnetic stimulation?
It comes down to that term supramaximal. You physically cannot recruit 100% of your pelvic floor muscle fibers through voluntary contraction no matter how hard you try.
Right.
And you certainly cannot contract them thousands of times in half an hour. The Emcella device bypasses your brain's limitations and forces a level of neuromuscular re-education, strength building, and endurance that is just impossible to achieve independently.
So it's rapidly accelerating the physical therapy timeline.
Yes. And it triggers another vital physiological response. Basic exercise physiology dictates that when a muscle undergoes intense, repeated contraction, its metabolic demand skyrockets.
Sure.
The body responds to that demand by increasing blood flow to the active muscle tissue.
So by intensely working out the pelvic floor, you are actively increasing the regional tissue perfusion, like the local blood flow to the entire pelvic neighborhood.
That happens, yes. But Dr. Ianculovici emphasizes a highly specific point about medical precision here. While the technology clearly increases regional pelvic circulation, she notes it has not been conclusively shown in controlled human studies to increase intraprostatic blood flow specifically.
Why does she make that highly specific distinction? Does it matter?
It does, because the regenerative wellness industry often overpromises. We have to stick to what the science actually proves. We can definitively say it increases muscular metabolic activity and supports general local blood flow, but we cannot legally or scientifically claim it directly perfuses the prostate gland itself to treat other conditions.
What's fascinating here is how these different interventions fit together without competing. Because if you don't really understand the mechanisms, you might think Emcella and the P-shot are rival treatments.
Right, but they address completely different physiological targets. Emcella rehabilitates the neuromuscular recruitment and the mechanical strength. The P-shot is attempting to repair the cellular environment and endothelial signaling.
So what does this all mean? We have all these disparate pieces, right? Metabolism, hormones, cellular scaffolding, physical therapy. How does a doctor actually put this all together for a real human being sitting in an exam room?
It requires total integration. Dr. Ianculovici synthesized this into what she calls the Morel method, which is a 4-pillar clinical model.
Okay, what are the pillars?
Pillar 1 is vascular and metabolic health. Pillar 2 is hormonal signaling. Pillar 3 is local regenerative biology. And Pillar 4 is pelvic floor neuromuscular function.
Can you walk us through like a hypothetical case study? How does a patient actually move through those 4 pillars?
Sure. Let's take a 55-year-old man with mild type 2 diabetes presenting with ED. In the old model, he gets a 30-day supply of sildenafil and leaves.
Right.
But in this new paradigm, the physician evaluates his fasting glucose and cardiovascular risk first. They might order a penile duplex Doppler ultrasound, not just to do it, but to visually measure the actual arterial flow and check for venous leakage.
Finding the specific structural failure.
Exactly. Then they build the treatment plan. They might prescribe a low-dose daily PDE5 inhibitor like tadalafil, not just for immediate erections, but to keep the tissue oxygenated overnight.
That makes sense.
Simultaneously, they work on aggressively managing his insulin resistance to stop any further endothelial damage. If his testosterone is clinically low, they introduce replacement therapy. If the Doppler ultrasound shows his vascular tissue is severely damaged, they might discuss PRP as an adjunct. And if his pelvic floor is weak, they incorporate neuromuscular rehabilitation.
It's a total systems approach. And I love that it doesn't just throw away traditional medications. It just refuses to use them as a blindfold.
That is the essence of precision medicine. You quantify the severity, map the cardiovascular and metabolic risk, identify which of the four pillars is the dominant failing system, treat the root causes concurrently, and objectively measure the outcomes using those questionnaires 3 to 6 months later.
This deep dive really isn't just about sexual health at all. It's a masterclass in how our biological systems are intimately tied together. If you are listening to this or, you have a partner dealing with ED, you shouldn't just accept it as some inevitable depressing part of aging.
Absolutely not.
And you certainly shouldn't settle for a Band-Aid solution that just forces a temporary chemical reaction. It is a literal alarm bell telling you to inspect your metabolic and vascular foundation before the house collapses.
And the interconnected nature of our bodies leaves us with a truly profound question to consider.
What's that?
If erectile dysfunction is demonstrably one of the earliest, most visible markers of systemic, vascular, and metabolic decline, what would happen if general practitioners started treating erectile health as a standard, routine vital sign?
Wow.
Just like we check blood pressure, heart rate, or cholesterol at every single annual physical. Could destigmatizing this conversation actually be the key to catching heart disease years before a cardiac event ever happens?
That is an incredibly powerful thought. Imagine saving millions of lives simply by being brave enough to look past the leaky pipe and actually inspect the foundation. Thank you so much for joining us on this deep dive and exploring these sources with us today. Keep asking those big questions, and we'll catch you next time.